morning. I'm City and State's John Lentz, and I'm pleased to welcome everyone to today's discussion about health equity in New York. There are plenty of directions to take that topic, but today we're narrowing the focus to the 340B program. Many of you tuning in know what that is, and if you don't, you will by the end of the program. We'll talk about the state's looming fee-for-service carve-out, the expected impact on the 340B program in New York, and what possible paths policymakers are considering going forward. But before we get to our panel discussion, we'll hear from a few speakers who will introduce the topic. First up, I'd like to introduce Jack O'Donnell, founder and managing partner of O'Donnell & Associates. Jack, over to you.
Thanks, Jonathan. I'm Jack O'Donnell from O'Donnell & Associates, a full-service public relations and government affairs firm. At O'Donnell & Associates, we believe our job is to help our clients make New York State a better place for ourselves and our families, but also for all New Yorkers. That's why we're proud to be in this fight with our client and friends at Trillium Health and so many others to protect the 340B program. Trillium does the real work, saving and transforming lives, but it really is our privilege to support them in that work. I'd especially like to recognize Harry Bronson, who has been leading this fight, and thank all of our panelists today. Now it's my pleasure to introduce Jim Moore. Jim is O'Donnell Associates Policy Director and has been our expert and our point person on this 340B crusade. Jim?
Thanks, Jack. Good morning, and thanks for joining us. I'd like to start with a huge thank you to all of our panelists, specifically Senator Gustavo Rivera, Assemblymember Dick Gottfried, Assemblymember Harry Bronson have been tireless advocates of safety net healthcare throughout New York State. Without them, healthcare in our state would look very different for the patients who need it most. They're dedicated to the fight for health equity, and at no time has that been more important than right now. The issue we're here to talk about today, the Medicaid drug benefit, is complex. It touches almost every area of the safety net, from harm reduction efforts around the opioid epidemic, to ending epidemic efforts around HIV, such as PrEP and PEP, to STI testing, and most recently throughout the COVID-19 pandemic. The foundation of these efforts for safety net providers across New York State is a federal program enacted in 1992, which, as the original congressional sponsors put it, was intended to stretch scarce federal resources as far as possible. Section 340B of the Public Service Health Act mandates that drug manufacturers participating in states' Medicaid programs provide discounts to covered entities. Covered entities include safety net hospitals, federally qualified health centers, federally qualified health center lookalikes like our client Trillium Health, and state-operated AIDS drug assistance programs, along with Ryan White Care Act grantees. Covered entities are in many cases the backbone of healthcare for the populations they serve. The 340B drug discounts result in essential funding for covered entities that allow them to meet the complex healthcare challenges for the patients. In short, 340B for many across New York State has become synonymous with health equity. Now, in 2020, during the darkest days of the COVID-19 pandemic, the state's Medicaid Redesign Team II reintroduced a long sought after priority for Governor Andrew Cuomo, the fee-for-service carve-out of the Medicaid drug benefit. I'll let my colleague Mark Malahosky get into the specifics, but suffice it to say, the fee-for-service carve-out, as it is currently in statute, would decimate the 340B program and wrap around services at covered entities that are so essential to adherence and linkage to critical care throughout the state. So, largely due to a fierce effort by covered entities across the state and the legislators joining us on this panel, including the National Coalition, Ryan White Clinics for 340B Access, 340B grantees, and perhaps most importantly, the Save the New York Safety Net Coalition. In last year's budget, we were able to delay the fee-for-service carve-out of the Medicaid drug benefit until April 1, 2023. Since 2015, I've had the pleasure of working with Mark Malahosky, a growing national leader on 340B issues. Mark knows this issue inside and out. His passionate work and policy focus are inspiring. The reality is that Mark and every panelist on this call are in this fight because they're dedicated to the health outcomes of the patients they serve. Again, Senator Rivera, Assemblymember Gottfried, Assemblymember Bronson, and all of our panelists today deserve deep praise for their hard work to understand the complexity of the 340B program and their dedication to finding a real solution. We look forward to hearing from all of our panelists today on the continued fight for health equity in New York State. Again, I would like to thank everyone for taking the time out at this busy time of year to hear from us about 340B. So with that, I would like to introduce one of the foremost experts in New York State on the 340B program, Mark Malahosky. Mark.
Sorry about that. Jim, thank you. Wow, that's a terrific introduction. It's a pleasure to be with all of you today. I'm going to focus my comments on the intersection of the 340B program and the Affordable Care Act and how what is happening in New York is of the intent of the ACA. Congress stated, as Jim said, the 340B drug pricing program was enacted, and I'm quoting, to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. In order to participate in the Medicaid program, pharmaceutical manufacturers must offer a statutorily defined best price to the federal government, done so through a rebate paid back to state Medicaid agencies. The 340B statute mandates that they must also offer a similar best price to 340B participating covered entities on the purchase of covered outpatient drugs dispensed to their patients. The 340B program is not grant or direct funding. Outpatient drugs are purchased at a discount by the covered entity. The drugs are dispensed through a prescription to patients of the covered entity. The covered entity is then reimbursed by payers at typical contracted rates, and that delta between the purchase price and the payment gives covered entities the resources they need to provide the necessary care and services to their patients, services that are largely under or unfunded. Now, the program was expanded as part of the Affordable Care Act of 2010, including significant changes in the Medicaid rebate and the 340B programs. Prior to the ACA, states could only collect rebates when Medicaid claims were paid for under fee-for-service. Manufacturers are protected by what is called the duplicate discount prohibition, which simply put ensures they do not provide a 340B discount to a covered entity and a rebate to a state Medicaid agency on the same claim. So covered entities did not have access to the benefit of the 340B discount on any Medicaid claims prior to the ACA. The ACA allowed Medicaid agencies to now collect rebates on claims paid for under a Medicaid managed care plan and no longer just under fee-for-service. Also, and by extension, and most importantly to what is happening here in New York, it allowed covered entities a pathway to be able to access the benefits of the 340B discount on Medicaid claims. The ACA created millions of newly insured Americans, and it was believed a majority would be seeking care from safety net health centers. Additionally, the ACA allowed states to expand their Medicaid programs for many of these newly insured. Accordingly, the ACA fully intended to provide covered entities an avenue to access the benefits of the 340B discount that they clearly would need to expand their services for all these new patients seeking care, including patients in Medicaid. However, because of the original 1992 federal statute, all prescriptions must be paid for by a Medicaid managed care plan and not directly by a state Medicaid fee-for-service plans for covered entities to access those benefits. Subsequently, in 2011, New York State Medicaid changed their outpatient prescription benefit from fee-for-service to managed care, now allowing covered entities in New York to access the 340B benefits for the majority of the Medicaid population, while still allowing the state to collect rebates on all non-340B prescriptions. In fact, in a September 2011 communication, the Department of Health alerted covered entities that they could now access the 340B discount on Medicaid claims and put processes in place to prevent duplicate discounts on claims using 340B. In summary, the ACA intended for the 340B program to provide resources to covered entities to expand access to care, and New York State knowingly put processes in place to allow covered entities a way to access those benefits. However, in Governor Cuomo's budget in 2020, the state sought to reverse the Medicaid outpatient prescription benefit back to fee-for-service, which means the resources that covered entities have been investing in patient care and services since 2011 will now be taken away. This is set to go into effect April 1st of next year. Now, the majority of safety net prescriptions filled in New York are Medicaid. So effective next April, the majority of prescriptions from the safety net will no longer be eligible for the 340B benefit. Now, these resources, as I stated before, are generated solely by discounts manufacturers extend to covered entities, and not at all by state taxpayer dollars. They will be suddenly removed from communities across New York where they are currently invested by statute to provide and expand patient care and services. Additionally, because of other changes made by the ACA specific to Medicaid rebates, and since New York is a Medicaid expansion state, the majority of these dollars that will be removed from communities across New York must then go to the federal government, upwards of 70%. So by forcing all prescriptions into the fee-for-service program, for every healthcare dollar being taken out of our communities from the 340B program in the Medicaid population, 70 cents will leave the state altogether and will go to Washington. And at best, 30 cents will go to the general fund and not even necessarily to healthcare. While the state has promised to make covered entities whole, there is no guarantee they will be made whole in perpetuity. And frankly, there is no way covered entities can truly be made whole. The numbers just don't add up. 340B is a federal program that has delivered on providing better health outcomes to patients. A national independent study was commissioned by Ryan White Clinics for 340B access, and it not only confirmed this, but it also concluded that taking away these resources will lead to poorer health outcomes. Subsequently, the cost for these poorer health outcomes will shift to other payer sources, including Medicaid and uncompensated care in hospitals, and ultimately to other consumers, the state, and thus taxpayers. Covered entities will be forced to cut programs and services, lay off staff. Some may be forced to close altogether. Patients that typically get their health care from safety net providers have histories of health disparities, often come from communities of color, and many are at or below the federal poverty level, and they all will be disproportionately harmed by this change. If this happens in April of 2023, New York State will be harming, if not dismantling, the safety net, and could, in all likelihood, increase costs to the state. Thank you.
Great, thank you, Mark. Appreciate you filling us in on the details here, setting the groundwork. We'll now bring up our panel. You can go and turn on your videos now. A couple notes first for our audience. There's a Q&A function. As time permits at the end, we may take a couple questions from the audience, so you can plug those in. I think you can give a thumbs up to questions you like to move up to the top of the queue. There is also a chat function for our audience. If you want everyone to see your comments or thoughts that you have, make sure you change the setting to everyone so everyone can see what you want to say in the chat. And please do keep it on topic and respectful. To our panelists now, we won't be doing any extended introductions or presentations. We have about 45 minutes here, a lot of ground to cover in a limited amount of time. So again, I ask you to keep your responses to 2 minutes or less where you can. Our panelists this morning are Assemblymember Richard Gottfried, Assemblymember Harry Bronson, State Senator Gustavo Rivera, Andrea DeMeo, President and CEO of Trillium Health, a community health center in Rochester. We have Michael Lee, the Chief Operating Officer of Evergreen Health, formerly AIDS Community Services, based in Western New York. Jomil Luna, Linkage to Care, AIDS Healthcare Foundation, a global health nonprofit, I believe, based in LA. And Matthew Bernardo, President of Housing Works, a New York City-based nonprofit targeting AIDS and homelessness. Now let's jump right in. We've heard a pretty good kind of briefing on what this is all about from Mark. And let's jump right in with a question. What is your view on this policy? What should be done going forward? Should this be repealed? Should it be delayed again? Should other funding be found? And State Senator Rivera, you're the chair of the Health Committee in your House, where I believe the State Senate has pushed to repeal this entirely. Let's start with you. What's your view on this issue?
Well, thank you for having me here this morning. I think, because I want to make sure that my colleagues also have a chance to chime in here. I want to make sure that whatever transition we have does not impact providers that use this program, this federal program, to be able to provide services to the most vulnerable. I can't be, now we certainly, I'm sure we're going to have a conversation about the impact that the lack of the transition does to pharmacists, and we obviously care about community pharmacies. But the reason why I was supportive of pushing this off is because we have to have a thorough conversation, and I'm happy that we're having it with this administration and not the last one, about how we do this thoughtfully, because any transition in this to managed care, or I should say to fee for service, needs to be done in a way that does not impact the providers who provide services for the most vulnerable, folks who are with substance use issues or are HIV positive folks. We have to make sure that those providers at FQHCs, et cetera, have to make sure that those providers can continue to do the things that they've been doing with this federal program. And that's why I'm glad that we're pushing it off a bit to make sure that we can do it softly.
Thank you, Senator. We'll follow up on some of that a little bit later, but let's go to Assemblymember Richard Gottfried, Chair of the Health Committee in your House. And I believe a year or so ago, you had, I think, pushed to delay it and not to outright repeal this and possibly provide or dedicate other funding here. What is your current view on what should happen on this front? Assemblymember?
Yeah, thank you. Well, the Medicaid carve out, I believe, is an important and sensible policy, because the Medicaid program, negotiating on behalf of 6 or 7 million covered lives, can negotiate much lower prices with drug companies than individual managed care plans negotiating on behalf of a few 100,000 covered lives. And also under fee-for-service Medicaid, prescriptions are protected by the so-called prescriber prevails rule, which guarantees much more choice for patients and their doctors as to what drug will be prescribed, as opposed to having the managed care plan dictate the formulary. I think the solution to the 340B problem is to make an exception to the carve out so that 340B prescriptions would continue to be purchased by the managed care plan so that it can take advantage of 340B, but that provide that for purposes of prior authorization and the like, governing the prescription, that would be covered by the rules of the fee-for-service program. I have a bill, Assembly Bill 7200, that would do exactly that, and I am hoping we can advance that. So again, it would put the carve out of the prescription drug benefit into fee-for-service in place, except for those prescriptions where someone was in a managed care plan and the prescription was through a 340B provider. Then it would stay, the managed care plan would be doing the purchasing, thus preserving the 340B benefit. I think it's a sensible solution, and I hope we can do it.
Thank you, Assemblymember. Let's go to Assemblymember Harry Bronson. You've been a point person on this issue. Also, you're a member of the LGBTQ community, a longtime advocate on matters like AIDS and HIV, in a population there that has been a direct beneficiary of this. Where do you stand?
Thank you, Jonathan, and thank you, City and State, for doing this important public service to educate folks regarding this issue and the impact, and glad to join my colleagues and others on the panel. Let me take a little bit of a different perspective here, and that is as a gay man in our society and whose life's journey followed the journey of HIV and AIDS. And knowing the lack of service in the 80s with very brave people like Dr. Valenti at Trillium, starting one of the first clinics in our country, and now has become Trillium, which now not only serves the LGBTQ community, but serves a large population of people of color, Black and brown folks in our community. And they rely on the 340B program to provide services to some of the most vulnerable people among us. Those services are comprehensive. Those services include many underfunded or not funded at all Medicaid through Medicaid, and they can't do this without the 340B program. They can't continue it. Andrea's on the panel. She can talk more specifically to this, but I mean, we're talking, millions and millions of dollars in my district. If we were to go forward with this proposal without making any changes, it would cost my district providers roughly $50 million a year. Those providers are not only Trillium Health, but Anthony Jordan and the University of Rochester Medical Center, all of whom provide services to vulnerable people that they could not do otherwise without the revenue benefit from the 340B program. It is not just HIV, but the opioid epidemic and currently COVID. Folks like Trillium stepped up. They helped the county Department of Health to provide the services needed during COVID, and certainly are very engaged in the opioid response. So, for me, like I think I heard the senator say, and the Assembly member Gottfried say, we've got to keep these organizations whole, whatever the solution is. The proposal for a grant doesn't work because it doesn't provide sufficient amount of money to replace the revenues that would be lost if we were to do away with the managed care 340B program. So, for me, this is a matter of equity, it's a matter of fairness, and it's a matter of justice. You can't leave my community out, and we can't leave communities of color out who are being served through this program.
A real quick follow-up for you, Assemblyman. Your colleague, Assemblymember Gottfried, had a sort of compromise proposal he laid out. There's legislation there. Have you looked at that? Do you have any position on that proposal?
Yeah, whatever we would look at, I would want to make sure that we are replacing the loss of these revenues through 340B, and that it's on an ongoing basis, and that there's some guarantee to extent possible that those revenues would be recurring year in and year out.
Got it. Thank you. And you touched on Trillium Health. Let's go to Andrea DeMeo with Trillium Health, the Community Health Center in Rochester. Over to you.
Thank you, Jonathan. Good morning. And I would like to thank Assemblyman Bronson, Assemblyman Gottfried, and Senator Rivera for their continued leadership and standing behind the safety net across New York State. I'd like to comment on what the carve out means to Trillium Health and the other safety net providers, and really on the ground terms. If this goes through as planned, the carve out, it would affect, as everybody has mentioned this morning, the most vulnerable in our communities. It means that all the work that we've done in our legacy service to serve the LGBTQ community and address the HIV epidemic, we would no longer be able to provide those programs for preventing and treating HIV. It just wouldn't be able, including pre and post exposure medications and innovative new treatments such as the new HIV injectable. It also means we would not have the funds to continue to invest in the opioid epidemic that Assemblyman Bronson just mentioned, and all the work we're doing to link people to care, distribute Narcan to reverse overdose, save lives, and keep people as safe as possible while using. It also means we would not be able to afford to pay the providers who will seek employment elsewhere. It means a loss of jobs. And it means we would not be able to provide the medically proven effectiveness of the comprehensive care model that integrates providers, pharmacists, behavioral health specialists with supportive services for our patients. This is the very model of care that keeps people out of the EDs and from being hospitalized. The result of the carve out is against everything that Medicaid redesign has been striving to achieve. It means turning our backs on the most vulnerable at a time when efforts to address health equity is critically needed, impacting primarily New York citizens of color, and instead of increasing access, actually closing the doors to people historically excluded from equitable, high-quality, affordable healthcare. I'd like to note that the governor's 30-day budget amendments call for increased investment and access to primary care, prenatal and postnatal care, maternal child health, and efforts to ensure health equity. Community health centers and Ryan White clinics are improving access to care. It's our legacy. We're bringing our mobile clinics to the highest risk areas and caring for those most at risk. Why suggest these investments and take away the 340B program at the same time? It simply does not make sense. We're asking to consider to repeal the carve out at this time and let us work together to find a solution that meets the needs for the transparency and cost savings that does not decimate the safety net. We can't wait until next April. If the delay remains versus repeal, we have no assurance of the funds we need to operate our clinics. The looming possibility of a carve out prevents us from investing in innovative care delivery models today and expanding our services if in fact we may need to in turn cut them next year, lay off our staff, and close many of our programs if we don't repeal the program this year. The 30-day amendments also calls for the investment in the Center of Medicaid Innovation to lower costs and improve care. We're eager to join this effort and work with the governor's team and the Department of Health to innovate a national model of care that we can be proud of in New York State, that meets the New York State objectives without disruption to the safety net, ensures continued access to life-saving treatments. We have a golden opportunity to be a leader in the care for all people. Let's repeal the carve-out now and invest our time and energy in innovating a model of care that we can all be proud of. We're asking to repeal the threat of the carve-out so we can build upon the work we've done in our communities for decades. The call to action that we fulfilled during COVID and ensure that our safety net is indeed still a net that's here across New York to care for our most vulnerable. We see it every day at Trillium Health. It is a distraction, the concern of the carve out. Let's repeal it. Let's find a way to work together and find a solution that meets everyone's needs.
Thank you, Andrea. And we have three more panelists to get to who are among the providers, those who are caring for the most vulnerable in New York. We'll hear from Michael, Jomil, and then Matthew. And if you could also, if you're able to address, what some of the lawmakers are talking about, maybe there is a way to make this transition go forward with providing enough money, making sure it's locked in, or is it just, absolutely you want to repeal this and just keep it as is? Michael Lee with Evergreen Health, let's go to you.
Thanks, Jonathan. Yes, I mean, I think that there's a lot of different ideas. I was part of the Governor Cuomo's 340B advisory group that was originally tasked with coming up with a solution and making non-binding recommendations. But I think that group really pivoted into just making recommendations of how to spend down that fund. And I think just based on the timeline, that we need to still ask for a complete reversal of this and work together on a carve out or work together on a solution that works for everybody. I just don't think that there's time to move forward in a year with something that works because it's so complex and the stakes are so high. And I'll just say, at Evergreen, how we use 340B, this is, actual like boots on the ground stuff. When COVID hit, the Erie County Department of Health came to Evergreen and said, we have to stop STI testing and treatment because we're doing contact tracing. Is there a way that, Evergreen can come in and help out with that? So we did. We were asked again to continue to do opiate overdose outreach. So we purchased another mobile van. This was all, prior to the Build Back Better resources. We continue to see an increase in trans youth. So we created a trans youth coordinator here in Buffalo. These are all resources, that we get from the 340B program that allows us to pivot in real time and use these resources. And without it, we're talking significant cuts. We would not be able to do the amount of outreach we're doing for overdoses, certainly emergency housing for our patients, all of these things that we're doing. Evergreen would face about a $12 million annual loss, and trying to prepare and run an organization facing that sort of a loss is really astronomical. And I know folks say that the fund, if we could make them whole, I want everybody on this call to picture trying to run and plan to run an organization for the next year with the uncertainty of what this fund looks like and the loss of $12 million annually. I mean, you're absolutely talking about patient cuts They're talking about a reduction in services. And this is at a time where we're seeing unprecedented need for mental health, opiate overdose prevention, substance user health, and the list goes on and on. So I think that we need to continue with reversing the carve out and come up with and continue and actually work together, not like the former governor's 340B advisory group, where they just wanted us to come up with a mechanism to spend down this fund, but truly work together and come up with a solution that leaves the covered entities largely untouched, but also gets the lawmakers what they want.
Quick follow-up with there, Michael. What would be a good window of time if a change like this goes forward to be able to phase this in, to be able to, not lose any of these services? 2 years, 3 years, like how would that work?
Whatever would allow us enough time to really plan. I mean, I just think of right now when we're meeting, in the summer about budgets, but we create 2 budgets. So, I mean, it's certainly not a year. I can tell you it's not a year. I would say it's probably 2 to 3 years of, because 340B is a complex issue. It's a complex issue on the federal, stage. It's obviously complex here on the state. And so there's a lot of intricacies of it. So I think that a year to come up with a solution is not ideal, and somebody's going to lose if that happens. I think that, if we could take 3 years to come up with a real solution and avoid what's happening in California and the mess that's happened there, I think we need to learn from that and try to avoid it at all costs.
Got it, thank you. We'll go to Jomil Luna. I believe your organization is based in California. I don't know if you've paid attention to the situation in California, but any thoughts you have, again, specifically here in New York, and anything else you want to add?
Sure. Thank you, everyone. So hello, everyone. My name is Jomil Luna, a pharmacy specialist and former linkage to care specialist at AHF. Thank you for the opportunity to speak today and share not only my personal story as an HIV patient, but also as someone who sees the day in and day out life-saving abilities of the 340B program. Before coming to AHF as an employee, I was a patient first. I first came to AHF in 2016 as a patient during one of the most difficult times in my life, where I struggled financially, mentally, and medically when it came to my HIV treatment. Although on the surface and on paper, people knew me as a public health professional, I myself found navigating the healthcare system and programs overwhelming and cumbersome. Patients such as myself have competing factors such as housing, food insecurity, daily stressors that lead to depression and anxiety, and still are expected to pull themselves together and have a roof over their head and have meals on the table that take precedence over things like linking to care and staying in care, also staying adherent to their medications, not to mention being able to afford their medications. I've since become an expert in knowing how to navigate all the issues I've mentioned above, but I still see this story repeated each and every day with our HIV and PrEP patients. As just a reminder, HIV obviously is still a problem here in the United States and around the world. New York especially is a safe haven for millions of people who need resources such as 340B to be able to stay undetectable. When we preach messages like U equals U, undetectable equals untransmittable, we must keep in mind that every stage in the continuum of care presents its challenges, from diagnosis to linkage to care, to medical care, to viral suppression. And you may ask why? Because we have to get patients through the door, and that in itself can be challenging. Which leads me to what 340B helps with. 340B assists patients with transportation to their medical visits, a dedicated linkage to care person or pharmacy specialist to make sure that patients can attend their appointments free of cost, navigate different insurance programs or care coordination programs that help navigate patients to different resources that otherwise they would not know how to feel, or they would feel overwhelmed trying to figure it out. 340B programs keep us nimble. We are able to act quickly to connect patients to care, retain them in care, and make sure they get to undetectable and remain healthy in addressing their overall healthcare needs. Some of the best examples of our patients succeeding under the 340B program is through our affiliates like ACQC and Iris House, where patients get access to food and nutrition programs, food pantry. When we're able to help our patients succeed through making sure they are healthy and happy, not only does the patient win, but everyone wins. In the long run, we are able to save healthcare dollars that are spent by people seeking care in the emergency room as the first line of defense, or not being navigated properly because they don't have the expert staff to speak to. If we learned any lessons throughout this pandemic, It's that we cannot forget about the most vulnerable, which oftentimes are communities of color, people with comorbidities, people that identify as LGBTQ. Thanks to 340B programs during the pandemic, we were still able to make sure that patients connected to care and got their life-saving medication. When the world shut down, literally and figuratively, as it can in many of our patients' lives, and as it did during COVID-19, we were able to still offer programs, and we never shut down. A day in the life as someone who serves patients is very fulfilling for me, because I see patients from start to transition, from scared and uncertain to secure and knowledgeable of the amazing benefits they are able to access through the 340B programs. I even have had patients that encourage their own friends to seek out care due to their amazing experience with us, because they proceed to explain that the experience at a non-340B entity was dry and cold, and that the providers didn't provide the same level of care as we did. As a 340B organization, we must continue to provide our patients with a voice to advocate for their needs, to continue to help them flourish through one-of-a-kind programs we're able to offer. One of the main things I hear from patients with many competing needs is that they want a one-stop shop, so that they don't have to miss work due to sick days or fear of losing their job. Through our 340B programs, we can provide wraparound services where patients find resolve and action. I hope that I've described here today, the story of a typical patient. 340B entities reinvest back into their communities, and we do what's best for the patient. And I want to say thank you, and it was an honor to share with you all today.
Great, thank you, Jomil. We'll go to Matthew Bernardo, President of Housing Works. Appreciate your patience. Over to you.
No problem. Thank you for having us. So I would be very clear. I think this should be repealed. I do not think it's there's several reasons. One, I think even the proponents will say it's disruptive. It's been disruptive since it's been introduced. Not only for planning, for community health centers, for planning, but even the rollout and some of the mechanisms that haven't been shown to us. Two is the math just doesn't add up. You can't drain from the safety net and have to give 70% back to the state, and then say you're going to make everyone whole in perpetuity, and no one's shown a mechanism in which this can be done. And then third, the disintegration of care. I think that many people, Assemblymember Gottfried, Bronson, and Rivera have been part of building the integrated care system that came out of the HIV/AIDS epidemic. We would be disintegrating that with the pharmacy benefit. The medical, the behavioral health, and the pharmacy are now together. Pharmacy is more important than ever as far as people's care. Now we have managed care that have sophisticated, robust member services. They have embedded pharmacists in there to reduce barriers. Pharmacies are on site. A lot of our contract pharmacies, our own pharmacies, are on site. They would not be able to survive on site. Even if you move a pharmacy across the street, your capture rate goes down 20%. It would really reduce access. And what our clients would be left with is an 800 number. As you start seeing some of the stories out of California, where there's 40-minute waits, 12-hour waits, people aren't getting their medication, and they're reduced to sort of having a call center that really doesn't understand there's data problems, there's all these kinds of problems. So really, I think it's a clean answer that I don't think it's a good policy. No one's shown us how this can help us. We can maintain the services, and then not just individual services. Sometimes they're whole centers. We have centers that are focused on drug user health. They're smaller centers. We do it. We don't make money on that, but we would able to sort of support that and support those kind of special populations that we would never be able to do. My last thing is 340B program works, and it works as intended. So I don't know what we're kind of going down this road.
Great, thank you, Matthew. And a couple of mentions have been made of California, and we actually have a question from the audience. Says a pharmacy benefit carve-out has already been implemented in California. what has that been like for patients, health plans, and health centers there? And let's start with maybe one or two of the lawmakers, if any of you have monitored what is going on in California. Is it working? Are we seeing the benefits that are supposed to come from this? Are we seeing the downsides? So Assemblymember Gottfried, if we could go to you, any thoughts on, where this is going, how this is going in another major state of California? And you're on mute.
I really can't comment on the California situation. I'm not familiar with it. But I would hope that the panelists and others who are involved with the 340B program would take a look at the bill that I've proposed, because I think by preserving the prescription drug benefit in the managed care plan, if it's under 340B, but carving it out if it's not under 340B, is a sensible solution and not particularly complicated. And I would hope people would take a look at that. Again, it's Assembly Bill number 7200. Take a look at it. I think it works.
Would any other providers like to weigh in on that, at least that concept, even if you haven't seen the legislation? Hey, Michael, you're on the
I think Mark might jump in on this.
Well, yeah, I just want to address the California issue for a second, if I can, because I've been actually working with a group out there, and California's a mess. It's not an exaggeration or hyperbole to say it's on fire. Folks are not getting their medications. There was an op-ed that was done that it's just a matter of time before somebody dies, and again, that's not hyperbole. It's a disaster. The entities have not, the fund that was promised to them, no one's received any of that revenue yet. So California is an indication of why we don't want to do this in New York. We are working with our colleagues out there to try to come up with a long-term solution, and we've actually been working for a couple of years on it. And I think there are solutions where we can keep the 340B program intact in managed care, ensure that the state gets all of what it's looking for, particularly on transparency, that pharmacies, because I am a pharmacist, that they're reimbursed fairly, which is not what's happening in the current system. So I think there's an opportunity for all the stakeholders to come together and come up with a solution that does not completely decimate the safety net. Looking at our friends in California and our colleagues and saying, we don't want to go there.
Got it. Thank you, Mark. Moving forward too, it seems like there is, agreement among everyone here. We want to continue to serve these folks, often low-income New Yorkers, LGBTQ New Yorkers, people of color. It's just a matter of how we get there, how we continue to do so. Do we have a sense, where the governor comes down on this? We've talked about, this was something that came out of the prior administration, the Cuomo administration. It was a very different time too. I believe there was an $8 billion budget gap. Now there's a federal influx of federal funds. We're still, maybe the tail end, we're still in a pandemic. But I'll go back to, does anyone have a sense of what the governor thinks? What has anything been proposed concretely, or are there other talks going on about this? Senator Rivera, start with you.
Well, there's certainly, this is a very different time, not only as it relates to the budget, but certainly as who is on the second floor. And I think that there's a demonstrated, the way, it's not just an attitude with the new governor. There's actually, I think that there's a commitment to work along with the legislature. So this is one of the issues that we're going to have to figure out. I mean, it is, it is still on the books that the transition is going to happen. There are approaches like the one that Dick is suggesting, but above all, I think I'm certainly looking forward to work with this administration, period. But on this issue, since we have an administration that actually looks at the legislature as a co-equal branch of government, that we can probably get to a good working solution. I'm hoping that we can.
I would agree with Gustavo that the Hochul administration is a whole lot more open and open to to negotiation and discussion than the Cuomo administration was, and that's very valuable. My sense from them is that they are still committed to the carve out. And as I said earlier, generally speaking, I believe the carve out is a useful thing to do and would save the state money. The question is not doing the carve out for the 340B segment. I think the health department still regards the 340B money that providers like Trillium are using. The health department still regards that money, still thinks that that should be their money, and can't sit still for the notion that it's automatically going to providers. So that's sort of I guess an ideological issue that we're going to have to work out with them.
Mm-hmm. Well, following that, isn't there an argument made that the current system allows for flexibility? You're outside the insurance restrictions. You're allowed to be more nimble and adapt. Using that money however you want to as a provider on the ground close to these vulnerable populations. Any thoughts on that?
Well, from the point of view of the health department, that's kind of a negative. The notion that money that they think belongs to them is going to providers who can use it the way the providers want to. The government attitude is if we think it's really our money and you're getting to spend it, we don't like the idea that you can just spend it the way you think serves your patients best. And that's an attitude that is, I imagine, not uncommon in government bureaucracies. They think it's their money, not money that the provider ought to be deciding how to spend.
Can I make a comment from Jonathan? So yes, I appreciate that perspective. From the provider perspective, it was the 340B that was the venue by which we were able to respond to COVID because it was unrestricted and the program works, as many have said this morning, where we could turn care operations, move to home delivery of prescriptions, turnkey our mobile access clinics, set up testing and vaccine site, partner with public housing, working with faith-based communities to get testing and vaccines into arms. So the very flexibility that the 340B program allowed us to fulfill the call to action, by the Department of Health, by our communities to be on the forefront and be first responders, which we were as safety net providers in all the communities across New York.
Absolutely. I would echo that, Andrea. At a time when COVID happened, it was that flexibility and our ability to be nimble and use those resources to address our needs in the community. When, by the way, the New York State Department of Health was withholding grant funds from us because of the budget. That's what the communities that we serve benefited from, that despite the Department of Health withholding funds.
And then I would say in the HIV arena, our safety net providers need that flexibility. There are so many areas of service that are not funded at all or underfunded that are key to saving lives and preventing the spread of HIV. If we're not providing transportation, if we don't have housing stability, if we don't have mental health counseling, if we don't have, I think one of the providers mentioned, the pharmacy right across the hallway, then we're not going to keep people on their medication regimen. And if they're not on their medication regimen, then they're not going to be able to maintain their undetectable level of the virus. And if they're not undetectable, then they can transmit. And the key to all of this is you save lives if you stay on the medication, and you prevent transmission if you're on the medication and you're undetectable, especially in populations when there are other issues that they're facing, whether it's substance use, whether it's mental health issues, whether it's a lack of housing. lack of nutrition. All of those things come together. And if we're going to, end the epidemic, then we have to have the flexibility that our providers are utilizing, and all of them mentioned today. And so I get it, and I agree with Assemblymember Gottfried about the attitude of the Department of Health. I'm hopeful that under this administration, that attitude might change. But we can't allow that attitude to prevent us from giving providers the flexibility they need in all of these areas of illnesses and treatments, but in particular, when it comes to HIV.
Sure. To be fair to the health department, I reviewed they have a FAQ on their website. The first question, what is the main objective of the carve out of the pharmacy benefit from managed care to fee for service? 1, provide the state with full visibility into prescription drug costs. 2, centralize and leverage negotiation power, something Assemblymember Gottfried mentioned. 3, provide a single drug formulary with standardized utilization management protocols. And 4, address the growth of the 340B program and associated reductions in state rebate revenue. Any response to those, on the surface at least, seemingly reasonable rationales from the health department on why to do this?
I could take that if any of my colleagues, if that's okay. Well, so all of what they said they want can be still done without moving everything over to fee for service, right? So there can still be a preferred drug list. They can still leverage the supplemental rebates, and definitely pricing transparency. And that's something, of course, the pharmacies desperately want. And I agree with that. As far as the growth of the 340B program, the reason the 340B program is growing is because there's an increase in need, particularly within COVID. So I don't see the growth of the program as a negative. I see it as a positive. More folks are getting care from safety net providers, getting prescriptions filled, getting better health outcomes. All of that's because of the 340B benefit. So I see growth as a positive thing, not a negative thing. And going back to, again, with the changes of the ACA, the money is going to be leaving New York State and going to Washington. But yet that's money, all of that's coming out of the community. So there's just going to be a net loss of healthcare dollars spent on patients in New York.
Thank you, Mark. Could any of the lawmakers hit on or respond to that last point, the argument that this will result in healthcare dollars going out of New York to the federal government? I've seen that in some stories about this as well. Or I guess, Mark, could you maybe elaborate on how that would happen?
Sure. So because New York's a Medicaid expansion state, when the state collects rebates, that money has to go back to the federal government because the federal government is paying for the Medicaid expansion, right? So it's a complicated calculation, and I think 70% is probably a conservative number, but it is money that has to go back to the federal government. But if it's 340B, if the money is, instead of through a rebate, if it's done through a 340B discount, the money stays in the community. And I maintain that was intentional by the writers of the Affordable Care Act, because as I said during my presentation, it was because patients are going to be looking to the safety net to get health care. So it was done intentionally to ensure that the safety net had the resources it needed for all of these new insured patients. And it's by statute that the money has to go back to the federal government.
Got it. Well, see, again, it seems like I think everyone's on the same page about maintaining the funding somehow. It's just a more matter of how you get there. But it seems like there is some agreement. We can't do this abruptly. There needs to be some kind of phase-in time. There needs to certainly be enough money going forward to, if this change goes forward, to continue to fund these services and programs. I guess, is there any disagreement with either of those issues?
I would just say that we don't have a managed care on this panel, but even some of the mechanisms that might be described as easy, simple, can make you whole, again, hasn't been sort of laid out. How are we determining 340B drugs from not 340B drugs if managed care is purchasing it? You need to have those clearly identified systems being tested, making sure it works. Again, as Assemblyman Bronson says, you miss PrEP, you are at risk. You do not take your antivirals on time. You miss it. Once you mess with a system that is already a complicated system that our clients are being navigated through, partly because of safety net resources, you blow that up. All of a sudden, it's not just a simple change here and there. I don't really believe that it's been laid out by anyone how this is going to work smoothly as presented.
Great, thank you, Matthew. We have about 4 minutes left. I will go to 2 audience questions. And Michael, I'd like to pose this one to you. Audience member says, the current carve out hangs over us like the sword of Damocles and doesn't allow us enough time for a thoughtful transition to a better pharmacy benefit option. Doesn't it just make sense to repeal the carve out now and create a high level group of stakeholders to create a workable solution? Again, you're part of a group that was ostensibly set up to do that very thing. Any response to that?
Yeah, I think that is, I think that to Matt's point, like we have to reverse the carve out as it is right now. And I think if you think about we're looking at a year from now, and I know that sounds like a long time and folks are fatigued with this issue, myself included, but when you think about it, we're already thinking about next year. We're already thinking about 2023. We're already trying to plan for it. So when I know we have a year to deal with this, and it might not seem that pressing, but if you're in the weeds of this, like Trillium and Housing Works, where you have a viral suppression rate of over 90% of your HIV positive patients, you're trying to make sure everybody's health outcomes are on par. Of course, you're thinking to the next year, how are you going to maintain that? How are you going to continue to do that, especially with this looming over your head? So I think first and foremost, absolutely, we have to reverse this carve out and take that sort of rain cloud over our head, because I can tell you as an organization that's trying to look for the future and figure out how we're going to care for our patients, it's there, even though it's a year out. And I think to Mark's point, there are things that we can do to look at increasing transparency and look into getting a single formulary, but all that takes time and it's complex, and there's federal statutes and state statutes. So we really have to do our due diligence, just like Matt said, like there's too much at stake here just to smush this through and have it all kind of fall apart. We have to do it in a more thoughtful way. I think we have to absolutely reverse this first and then circle back out and see what kind of solutions we can come up with. But there's just too much at stake, from viral suppression to PrEP patients to the opiate epidemic. There's just too much going on, and these resources are already being spent in our community, and it's taking them away is at a great loss to every community we serve.
All right, we have about a minute left. Since we have Senator Rivera and Senator Gottfried on, I'll take this audience question. Have the Health Committee chairs spoken yet how passing the New York Health Act would address the challenges caused by the carve out and the repeal of 340B? If one of you could weigh in on any thoughts on that?
Yeah, well, the New York Health Act solves a whole lot of problems. And by the way, we have amended the New York Health Act bill to include language similar to Assembly Bill 7200 to protect the 340B carve out. The 340B benefit. So that language is in the New York Health Act to protect 340B.
There you go.
All right. Well, we are about out of time. I want to just thank you all. Thank you to our panelists for this great informative discussion. Thank you to everyone in our audience for tuning in. And this concludes our program.